If a surgeon grafts a piece of perfectly healthy skin from a patient's leg right onto their arm, it stays leg skin. It heals, it adapts, it functions.
Right, totally normal.
But if that same surgeon uses perfectly healthy genital skin to rebuild a urethra that's been damaged by lichen sclerosus, the disease will it almost miraculously wakes up.
Oh, yeah, it absolutely does.
It recognizes the local tissue and just destroys it all over again.
Which is wild.
Welcome to our deep dive for today. We are looking into a custom deep dive on the urological surgeries deployed against advanced penile lichen sclerosus, which is also known in a lot of the literature as BXO.
Yeah, and what's fascinating here is that it's a phenomenal biological anomaly, like a uniquely frustrating one for reconstructive urologists.
Right.
What we're really looking at today is a battle of, architectural geometry and tissue behavior. When someone's urinary and sexual function is severely compromised by this disease, the standard playbook for tissue repair, you basically have to throw it completely out the window.
Okay, let's unpack this for you. We've got a massive stack of medical guidelines, surgical leaflets, and urology journals in front of us.
Yeah, plenty of reading material.
Including data from the British Association of Urological Surgeons, the BIUS, to really figure out what the surgical toolkit looks like when conservative treatments just completely fail.
And they do fail, frequently.
So to set the baseline from the sources, we know LS is this progressive inflammatory skin condition, right? It causes these porcelain white plaques, really severe tissue fibrosis, and strictures.
Exactly, which is a narrowing of the urinary tract. And we also know that topical steroids are the absolute first line of defense.
Always the first step.
Right. But looking through these clinical timelines, the big question is the tipping point.
Yeah, when does a urologist look at this and just decide, you know what, abandon the creams, we need a scalpel?
So the clinical threshold is largely defined by this thing called the 3-month rule.
3 months, okay.
Yeah, the standard of care basically mandates using these ultra-high-potency topical steroids, something like clobetasol usually.
Which is super strong.
Very strong. But if a patient has been rigorously sticking to that regimen for 3 months, like actually using it every day, and they still have persistent severe phimosis or meatal stenosis.
So a really tight foreskin or a narrowed opening.
Exactly. If that's still happening, conservative management is officially a failure.
Wow, just 3 months and they call it.
Yeah, because by that point, the actual tissue architecture is just too profoundly altered. A topical anti-inflammatory can't just reverse a physical structural blockage.
It makes sense. It's too far gone.
Right. At that juncture, surgery is basically the only definitive path forward.
Boy, are there any scenarios where they just completely bypass that 3-month clock? Where they just go straight to the OR?
Absolutely. And the biggest, most critical trigger is suspected squamous cell carcinoma.
Penile cancer.
Yeah. The literature is extremely clear about the link between chronic LS and malignant transformation. So if a clinician sees a lesion with any suspicious morphology, ulceration, nodularity, anything like that, you simply cannot trial a steroid cream.
Because it's just too dangerous to wait.
Exactly. The priority shifts instantly to getting a biopsy. Diagnostic uncertainty will always accelerate that move to the operating room.
That makes total sense.
And, there's also just patient preference. Some people would rather have a definitive surgical fix than deal with endless, basically lifelong cream applications.
Sure. But, okay, looking at this progression, jumping straight from a topical cream to, surgical reconstruction feels incredibly aggressive.
It does sound like a big leap.
Right. If you look at cardiology or gastroenterology, when a tube narrows, the very first instinct is dilation.
You stretch it out.
Yeah. You use a balloon or a stent. So why is the urology literature so, unanimous in basically condemning long-term urethral dilation for LS? Why can't they just stretch it?
It's a really vital question, honestly, because mechanically, stretching a narrow tube makes logical sense.
Right.
And a urologist might even try a short course of meatal dilation just for immediate temporary relief if a patient literally can't pee.
Just to get the flow going.
Yeah. But you have to look at the cellular environment of lichen sclerosus. You aren't just dealing with a standard passive blockage.
Right. It's an active disease.
Exactly. It's actively inflamed, highly fibrotic, really hostile tissue. When you push a dilator in to stretch that specific tissue, you inevitably cause micro tears in the epithelium.
And the body's natural response to tearing is to rapidly deposit more collagen, which in this case
just means more scar tissue.
Which is exactly what you don't want.
Precisely. You're triggering this nasty cycle of trauma and fibrosis. but structurally it actually gets even worse.
How so?
If the stricture stays narrow, the patient has to void under really high pressure, and that high-pressure urine gets physically forced sideways into the delicate periurethral glands. Yeah, it's called extravasation, and urine in those glands triggers an intense inflammatory response deep within the corpus spongiosum.
So the whole area just gets inflamed.
Right, leading to profound spongiofibrosis. So by relying on dilation, you are essentially pouring gasoline on an inflammatory fire.
That sounds terrible.
It is. You just can't stretch LS tissue into submission. You have to physically cut it out or bypass it completely.
Okay, and that structural reality really dictates the entire surgical approach here, which, looking at the sources, usually follows the actual geographical path of the disease itself.
Right. It moves in a specific direction.
Yeah, since LS typically travels distal to proximal, meaning outside in the surgical toolkit, starts at the absolute outermost layer, the foreskin.
Correct. When you have a patient where the LS is confined strictly to the foreskin or the glands and the proximal urethra is totally fine, the absolute gold standard is circumcision.
Just take it off.
Just completely remove the prepuce. It fundamentally alters the local microenvironment.
It's kind of like removing the fuel source from an advancing fire.
That's a great way to look at it.
Because the foreskin, it traps moisture, urine, and all those inflammatory mediators right against the glands.
Right.
So if you take that tissue out of the equation, it seems like you'd immediately halt that localized cycle.
And the clinical data backs that up completely. The sources actually highlight a really comprehensive study of 287 patients.
That's a solid sample size.
It is, and it showed that circumcision alone yielded an extraordinary 92% long-term cure rate for early-stage LS.
92%. That is massive.
It really is. What's even crazier biologically is that if there is mild early-stage LS on the glands itself, that tissue can actually revert back to normal.
Wait, really? It just heals on its own?
Yeah, simply because the diseased prepuce is gone and the glands is now exposed to a dry environment.
Wow. I mean, that 92% cure rate is incredible, but I want to make sure we don't just gloss over the reality of the surgery for you listeners.
Sure, it's still surgery.
Right. The British Association of Urological Surgeons has this very candid leaflet about the post-op reality. Medically, sure, it's a simple excision, but the patient has to deal with 7 to 14 days of significant swelling.
Yeah, it's uncomfortable.
And practically all of them endure a period of really intense hypersensitivity, while the glands gets used to just being exposed all the time.
That's a big neurological adjustment.
Plus, there's a standard 1 to 2% risk of localized infection that would need antibiotics. So, I mean, it is a permanent alteration of the anatomy. The pre-op consult has to be super thorough.
It is a huge change, yeah. But if you contrast that against the relentless progression of LS into the urethra, it's a highly favorable trade-off.
Okay, but what happens when the disease outpaces that? If the inflammation has already aggressively attacked the urinary meatus, the actual opening,
Right.
Circumcision alone isn't going to fix the flow. The nozzle itself is basically choked.
And at that point, the patient is dealing with severe meatal stenosis.
Right.
The symptoms here are awful. Highly obstructive voiding, splitting of the urinary stream, significant pain. So the objective is obviously to enlarge the opening.
Make the hole bigger.
Basically, yes. But the geometric approach is absolutely everything here. The literature strongly warns against something called a simple ventral metotomy.
Which is what exactly?
It's where a surgeon just makes a straight longitudinal cut to widen that fibrotic ring. And if they do just that, it is almost entirely doomed to fail.
Let me guess. Because of that microtrauma cycle we talked about.
Exactly.
You make a straight cut, and it leaves 2 raw edges of actively diseased tissue right next to each other.
Right, and they just want to heal together.
So during the healing phase, the scar tissue just bridges the gap, pulls tight, and the hole closes right back up.
Restenosis rapidly, yes. So to outsmart that scar contraction, urologists use an extended meatoplasty.
Okay, what's that?
It's a much more complex tissue rearrangement. The surgeon essentially creates a hyperspatic meatus. They physically relocate the urinary opening slightly backward, venting it downward into healthier, unscarred tissue.
Oh, wow.
Yeah. There's a key study by Morey, cited in our sources, that tracked this, and they found an 87% success rate.
Even in bad cases.
Even in heavily scarred reoperative fields where older procedures had already failed.
That is impressive. The sources also talk about this other one, Malone's technique for meatal stenosis. And the engineering of this is just
It
Fascinating.
really is an architectural fix.
It uses this highly specific V-shaped relaxing incision combined with dorsal and ventral cuts. Because, when you look at how scars behave, they contract linearly,
Right, they pull in a straight line.
like a drawstring closing a bag.
Right.
But by using a V-shaped geometry, Malone's technique physically interrupts those linear vectors.
The scar literally can't pull the opening shut because the forces are dispersed across different angles.
It's brilliant.
Mm.
And the recurrence rate is incredibly low. But here's where it gets really interesting.
Oh, the fluid dynamics.
Yes. Altering that perfect circular geometry of the original nozzle introduces a major functional quirk. You cure the disease, but you fundamentally disrupt the laminar flow of the fluid.
Right, it's not a smooth pipe anymore.
Exactly. This is that crazy fluid dynamics trade-off that makes reconstructive urology so wild. The sources note that around 15% of patients who get Malone's technique end up with a spraying urine stream post-op.
15% is a lot.
It is. As a surgeon, you are walking an absolute tightrope. You have to aggressively redesign the architecture to stop a fibrotic disease, but you also want to leave the patient with mechanics that actually work in everyday life.
And for a patient, choosing a 15% chance of a spraying stream versus the daily agony of not being able to pee, that's usually an easy choice.
Oh, for sure. But it takes some deep, informed consent.
Absolutely. And that fluid dynamics challenge, it gets exponentially harder when the disease moves beyond the mesos.
Moving further up the pipe.
Exactly. When LS advances proximally into the anterior urethra or causes panurethral strictures, which means really long, continuous segments of the pipe are just choked with dense plaque.
Right.
Altering the nozzle at that point is completely insufficient,
Yeah, you're looking at a total system failure. The main pipeline is just completely compromised.
which necessitates the most intensive intervention they have, the urethroplasty.
A major rebuild.
Yes.
Yep.
This involves total surgical excision of the diseased segment of the urethra, followed by a complete architectural rebuild.
And this can be done all at once. Right.
Depending on the stricture length and the vascular bed, it can be a single-stage operation, or it can be a complex, multi-stage procedure requiring months of healing in between.
And as I was reviewing the clinical guidelines for urethroplasty with LS, there's this one directive that just stands out so starkly.
The golden rule.
Yes, the golden rule. It reads less like a recommendation and more like an unbreakable law. Urologists must never, under any circumstances, use genital skin to reconstruct the urethra in an LS patient.
Never. And for very good reason.
Because in standard reconstruction, like for trauma or something, using skin flaps from the penis or scrotum is totally normal and successful.
Highly practical. But if a surgeon uses genital skin in an LS patient, the recurrence rate of the stricture skyrockets to an astonishing 50 to 100%.
Up to 100% failure rate.
Yes. The local tissue is intrinsically primed for the disease. The disease will just eat the new skin.
It's such a clear mandate. I mean, think about it like this for you listening. If you're a structural engineer replacing load-bearing beams that have been entirely eaten by dry rot,
Right.
you cannot patch that structure with wood taken from the exact same damp, rotting pile in the yard.
Exactly.
You have to bring in completely new, weather-resistant materials from somewhere else entirely. So in this surgical scenario, they import that resistant material from the mouth.
Specifically, buccal mucosa grafts, BMGs.
Oral mucosa grafts, OMGs.
Right. Surgeons harvest a robust strip of oral mucosa from the inner cheek or the lower lip. And the clinical outcomes using BMGs are heavily favored.
The success rates are huge.
Very. Single-stage oral mucosa graft urethroplasties show excellent long-term patency rates, ranging from 65 to literally 100%.
But why the mouth? What makes the inner cheek such an optimal donor site for this disease?
Well, if we connect this to the bigger picture, it really comes down to tissue resilience and environmental adaptation.
Okay.
The buccal mucosa is incredibly rich in vascularity, which means when you move it, it promotes rapid imbibition and inosculation.
Meaning it hooks up to the new blood supply super fast.
Exactly. Plus, the inside of your mouth is naturally adapted to a constantly wet bacterial environment, so it's a highly logical substitute for a urinary tract lining.
That makes total sense.
And most importantly, oral mucosa appears to be highly resistant to lichen sclerosus itself. Even when you place it directly into the geographical zone where the disease started, the graft basically refuses to adopt the fibrotic behavior of the surrounding genital tissue.
It is a brilliant physiological workaround, but man, a multi-stage urethroplasty taking skin from your mouth, that is a grueling, complex procedure.
It is a lot for a patient to go through.
What happens if a patient just cannot endure that? Like they have a devastatingly long stricture, or they're older and have, heart or lung issues that make long surgeries too dangerous.
Right. If a urethroplasty is contraindicated, or if they've already had multiple failed reconstructive attempts and the local tissue bed is just exhausted,
Well, what's the backup plan?
the definitive alternative is a perineal urethrostomy.
Now, that is a profound anatomical reroute.
It really is.
By bypassing the anterior urethra entirely, the surgeon brings the healthy proximal part of the urethra down, and they construct a new meatus, a new opening in the perineum, basically behind the scrotum.
It is the most radical alteration in the entire toolkit.
Because of the new position, the patient has to sit down to pee for the rest of their life.
Yes. And the psychological hurdle of that transition, it really cannot be overstated. It heavily challenges ingrained concepts of body image and daily routine.
I would imagine the pre-op counseling for a perineal urethrostomy is one of the most intense conversations a doctor can have with a patient.
It requires immense clinical empathy, for sure. You are proposing a permanent, life-altering shift in their daily mechanics.
But the research actually supports it, right?
Oh, completely. The post-operative data reveals a very powerful shift in perspective.
How so?
For severe cases, we're talking patients who have spent decades locked in this cycle of acute urinary retention, agonizing dilations, emergency catheters, constant infections.
Just living in misery.
Exactly. For them, a perineal urethrostomy frequently offers a massive, immediate upgrade in their quality of life. The daily, exhausting battle against the physical blockage is just definitively over.
The fluid dynamics are safely restored.
Right. They can void without pain or obstruction. The success rates and the patient satisfaction metrics, once they get past the psychological adaptation, they're exceptionally high.
So what does this all mean for you? Unpacking all these sources really reveals just how highly adaptable the urological toolkit is when deployed against advanced penile lichen sclerosus.
It's a very robust toolkit.
The overarching theme is that surgical success relies entirely on matching the exact geographical progression of the disease to the right architectural fix.
Precisely.
You don't jump to a mouth graft if the disease is only on the foreskin.
Yeah.
You just do a circumcision, remove the environment, and grab that 92% cure rate.
Right.
If it hits the nozzle, you use the geometry of an extended meatoplasty, or Malone's technique, to outsmart the scar vectors.
Yeah.
Even if you have to accept that 15% chance of a spraying stream.
Because the trade-off is worth it.
Exactly.
Yeah.
And when the main pipeline is compromised, you rely on the biological anomaly of the mouth grafts to rebuild the whole system.
That is the exact strategic escalation. But the most crucial takeaway from both the AUA and BAUS guidelines is that surgery isn't the finish line.
It's not over.
No. Because of that established link to squamous cell carcinoma, an LS patient is basically never truly discharged.
Even after a flawless urethroplasty.
Even then, they require rigorous lifelong surveillance because the architectural fix does not eradicate the underlying systemic risk.
And regarding that underlying systemic reality, there is one specific, deeply curious detail buried in these journals that totally reframes how we view this condition.
Oh, the long-term recurrence data.
Yes. We spent a lot of time talking about how robust and disease-resistant those mouth grafts are. But the clinical literature documents this haunting caveat.
It is wild.
Even after a highly successful urethroplasty where they use non-genital oral tissue and it perfectly integrated and functioned flawlessly for years,
Right.
LS has been known to mysteriously recur directly within that oral graft up to 10 years later.
It's a stark reminder of the limitations of our medical understanding, honestly. We can rebuild the plumbing, but the fundamental systemic mechanism of the disease, it's highly elusive.
It fundamentally challenges the modern medical definition of a cure.
Yeah, it really does.
I mean, if a surgeon rebuilds a urethra and you pee perfectly for an entire decade, every metric would call that a resounding success.
A total win.
But when a chronic inflammatory condition can just lay perfectly dormant in the body for 10 years, completely silent, only to suddenly wake up and attack a newly built graft that's supposed to be immune.
It forces you to ask a much larger biological question.
Exactly. When we use these advanced surgical interventions for severe fibrotic conditions, are we ever truly curing the disease? Or are we simply resetting a 10-year biological clock?
That is definitely something to think about.